learning as you feed data. And the final one is deep learning, which is probably the holy grail, where the computer receives independent inputs, it learns based on the inputs, and then it gives a desired output. So there's a big spectrum between AI and deep learning. And often when you explain to people, they kind of see the deep learning thing where you just throw data at a computer and it'll work out what's going on, to the more basic end of the spectrum, which is AI. And I think at the moment in healthcare, we're still very much on the early aspect of it. We're nowhere near deep learning or even machine learning to a degree. So this all started things off. So in the UK, Google have been working with the NHS and a company called DeepMind, which is a spin-off from Google Health Department. And using their AI and artificial intelligence, they cracked a 50-year-old solution about protein folding. So this is something that's really troubled scientists for years, about how proteins actually fold, basically. And with Google and DeepMind, they cracked it about a year ago, which was a breakthrough in the world literature. So machines are coming, and we're using a lot more of the machines to help us with our basic tasks and daily tasks, also in our scientific input. So what are we doing and why we're doing it? So in the United Kingdom, NHS, since COVID now, we've had a lot more patients to treat, a lot more cancer, a lot more problems. And in the NHS, we use the use of a multidisciplinary meeting. So I'm not sure if you guys are familiar with this, but the surgeons, the oncologists, the radiologists, the pathologists all sit down and discuss patients and discuss their care. And at present in my institution, we probably discuss about 100 patients a week. And we did a study about a year ago, looking at how much time we spend. And on average, at the beginning of the discussion, for the first half of the patients, we spend on average about 60 seconds discussing each patient and formalizing a plan. By the end of the meeting, we looked at the data and we spend about 20 seconds discussing patients. And we know that the patients that are put at the end of the meeting are probably the most complex patients that we talk about. And we know we're just not doing a justice to them. MDTs can be very long, they get boring, you get fatigued, and you want to just get through the MDT so you can go on and rest of your day. So we know that we're not serving our patients well in the way we manage their cancer care. And in the NHS, this is the standard now. Every cancer patient has to be discussed in a multidisciplinary meeting. Actually, I've been fortunate enough to join the Lagos Cancer Hospital for the last 6 months, and I joined the multidisciplinary meeting once a month to discuss cancer cases. So even in Nigeria, in Lagos, MDTs are happening, and I've been fortunate enough to be invited to discuss cases on a monthly basis. So this is happening in Africa and around the world as well. We think that we can use the use of artificial intelligence to help us with those decisions and really help standardize the care, so every patient gets the same quality discussion and the same in the same manner as well, basically. In our NHS, we know that we're spending a lot of time in MDTs, and we think with the use of AI, we can probably, and the government's really made it a priority in the UK. So they spent £150 million to increase the use of artificial intelligence systems in our UK public health system. There was a study looked at by Cancer Research UK. They found there's not enough time to discuss patients in the MDT, and they did it for a lot less as well from our own data. And we know we're rushing through patients, trying to get through as many patients as possible. And since COVID, it's only got worse. We know that we're trying to improve clinical management for all patients in NHS, to improve consistency and make sure that the care is transparent. We want to use the best clinical and diagnostic time in the MDT, because you've got a lot of surgeons, oncologists, nurses, and is it appropriate for them to be sitting in a room for about 3 hours discussing many cases when we could be looking after patients? So there's a real need to try and streamline these meetings and get good value for money and make sure patients are getting the best quality discussions as well. In MDTs, we know that in the UK especially, patients are not consulted in this. The doctor makes his decision in MDT, and the patient then is told what the options are or what the option is and have to accept it. So how do we incorporate patients' wishes into this process as well, so that it's really patient-focused care? So this is where the project was born, and we're evaluating the Deontics artificial intelligence platform for evidence-based treatment planning in multidisciplinary care to make sure that the patients are having good compliance with national standards and streamline in cancer care. And we call it the Prosaic DS, or Prostate AI Cancer Decision Support Study. We awarded just under £1 million from the government, and the rest was from the technology company. So £1.2 million in total that our team was awarded to look at the use of artificial intelligence systems in our multidisciplinary meeting using the Deontics platform. So the Deontics tool we've designing uses clinical recommendations, which is concordant with UK practice. But this doesn't have to be UK guidelines. It can be American guidelines, your local guidelines in Nigeria or Lagos or in your hospital. We're using patient values. So we get patient specific data. So patients are really at the key of these decisions that we make. We feel that with this tool, we can actually use it as a triaging tool. So if we had 500 cases in there, we can use a tool to cut out about a third of the cases, because we know with low volume, low risk cancer, it's always managed in exactly the same way. So we don't have to take up time in our MDT, clogging up with all the basic cases. The AI, artificial intelligence, can pull them out and give us a decision instantly in seconds. So we're looking at that as well. And at the moment, we're doing streamlining. So a human has to sit down and go through all the cases each week and pull out the basic cases. It takes about 2 to 3 hours of a consultant's time to do this, and a nurse. And with our AI, we can do this in seconds. So it really frees up time to then that consultant can then spend time looking at patients, looking after patients, performing surgeries, rather than sitting there with spreadsheets, going through patient lists. With variation. So if you have surgery in one part of the UK, in London, it may be very different to the outcome in Manchester or Birmingham, which is another part of the UK. So we think that with this tool and standardizing the care with the AI, it means that everyone is getting the same quality of decision, wherever you are in the UK, in Nigeria, in any part of Africa. And we think we can then streamline to give really accurate clinical care based on local guidelines. I've got a very strong team behind me that we've managed to amass. So those are teams, oncologists, surgeons, research fellows. We've got a large charity called Prostate Cancer UK, who are UK charity, our partners. We've got the Deontics technology company as well, and King's College London, which is the university and medical school, who are all part of the team behind the project we're doing. And this has never been done in the world before, and we're the first to try this out. So Deontics are our partners we work with, and they produce the artificial intelligence software system. So this is a familiar sight in the United Kingdom. On a Tuesday, the doctors, the nurses, the pathologists, the radiologists sit around a room for about 3 hours, and we discuss each patient. So the junior doctor often presents the case. We look at the scans, we look at the histology, we look at the patient factors if we have it, and we all come up with a consensus about how to manage this patient. And we do this week in, week out for about 3 hours a day, sitting around the room. Since COVID happened, we've not been sitting face to face. It's all been done virtually. But we go through about 100 cases a week in our hospital. Very, very busy. So this is a familiar sight to us. And in Lagos as well, I've been joining the MDT. Exactly the similar setup as well, basically. Just me coming remotely. So what we have is our clinical database. So all the patient's information is already stored on our databases. This can be adapted to Africa. So if you haven't got a patient electronic record, you can put this in manually and use the software, the AI as a database as well. So it's not just applicable to work in the US or United Kingdom. So all the patient information is stored in here. And this is the AI software here. So as we go through the cases and the patient information is populated, you can see here that the clinical information is here. So a 55-year-old gentleman with a PSA of 8. He's had his prostate biopsies, which shows Gleason's grade 3. His performance status is good, and he's got no lymph nodes. So this is a low risk prostate cancer. The information from the pathology is also put up here from the pathology department, and the radiologist would have already gone through the scans, like the MRI scan or CT scan, highlighting where the abnormalities and giving us a report. So this report shows that this is an abnormal prostate gland here. It's 50 grams. It's a T2B, so it's a localized prostate cancer on imaging. The AI will then give us a solution based on that. So it takes all the patient characteristics and tells us what the best practice is and what the preferred treatment is. So you can see here that this is a low risk prostate cancer. You can watch this. You don't have to treat at present. If the patient, the other option is radical prostatectomy or radiotherapy. So these are the options that have been pulled up from the artificial intelligence based on the patient characteristics. It will then give you the patient overall survival based on the patient's information. And another thing is, in the UK, we're very hot on clinical trials. So there's a clinical trial available. The artificial intelligence will also tell you that there's a trial this patient can enroll into based on their factors here. So as I said, this is the clinical information here from the end input in, and the artificial intelligence system will then give you an outcome based on your parameters here. And it can be put in manually as well, so you don't have to have the data automatically put in. In our center, we ask the junior doctors and the nurse specialist to then insert the patient information for each patient during the MDT, and the artificial intelligence will then keep a record of it and then print that off for consultation with the patient. And you can see active surveillance. If you want to, you can click into the link and it will give you an area in the guidance exactly where it's pulled that information from. So it's all very transparent if you wish to look at it. The second part of our study is looking at the patient portal. So the MDT has been done. The patient has their recommendation, and we've designed the patient portal. So in the consultation with the patient, you can go through the portal. The patient can look at it in advance and see what the decisions are once they've been told they've got cancer, and actually look at their complete a patient questionnaire. So the questionnaire asks patients about what's important for them. So, for example, is it return to work? Is it incontinence? Is it erection problems? These are specific to prostate cancer. And once that questionnaire is completed, the AI will then look at what the MDT has decided and offer the best treatment for the patient specifically based on their own characteristics. It can also look at your risk of relapse in 5 years. So it'll tell you, based on your own data, what's the chance of this cancer coming back. So you can then fiddle around to see if you have radiotherapy or surgery, how does it affect your patient outcomes? You can then also click on this link to give you patient information leaflets, so the patient can then look through all the booklets regarding radiotherapy or surgery, and it really gives them an informed decision about what type of treatment that's best for them. And I know some of you are probably thinking, we don't have time to do this, we see a lot of patients. Absolutely, but this can be done in their own time. So when they come and see you, it's a really more valuable discussion because they've had time to go through things, digest, ask questions and go back. And the patient has access to this 24/7. It can be adapted to locally as well. So we're able to change the languages. So it's not just in English, it can be in your local dialect. And also the questions can be more appropriate to your patient population. So things that are more important to a Nigerian population can be asked as well. So really this is customizable to any jurisdiction in the world. We just happen to use this in the UK, and this is what we use for our London population, both black and white. So this flow diagram just shows us how our study protocol and how we're going to do this. So you've got the responsible consultant who has to review all of the cases beforehand and put them through to the MDT. What we're planning to do is put all the cases through the AI tool with a single consultant review, and decide which case can be pulled out of the MDT and which can be streamlined straight to towards discussion with the patient. But after we've done that, all the cases are still going to go through the MDT to make sure the AI is safe and appropriate. We want to make sure that it's almost like double checking the decisions to make sure that the first part is the artificial intelligence given appropriate and clear decisions. Are they safe? We've started already with a very basic decision support system, and we've got 500 cases historically of cancer, and we've asked our surgeons to rank what they think the best treatment is for the patient. So this is all to train the artificial intelligence, so that the AI can understand what goes into decisions, and based on a fixed patient variables, what the humans are likely to pick for these cases. So we're training it now, and with about 400 historical cases. This work has just been completed, so we're going to publish this first. The second part is when we turn on the AI for real, live, and this is the world first. So all the cases go through for triage, and the AI will then automatically pull out cases that are very straightforward, so low risk cancer that do not need to be discussed in our meeting. And then the patients will then be brought in and then be sat down with their oncologist or surgeon or doctor to discuss the management of those ones. And the rest of the cases will then be randomized in our discussion to have the AI switched on or switched off. So the patients, so the doctors won't know if it's on or off. And in the background, the AI is giving recommendations. At the end of 6 months, we then compare what the human multidisciplinary team came up with each patient compared to AI, and see if the AI was more accurate or less accurate, and if there's any issues, basically. And this is where this is really truly a world's first. So we've never had a clinical AI system embedded in real patient practice in the world before. And this is where we really test out the system in a real life, busy hospital practice. Again, you're probably thinking, well, this is all fantastic. This is great for the UK, we have money, but how can this be used in Nigeria, Africa? And again, I think this is where during these MDT discussions, the doctors can input the information in, and it can also help guide regarding the appropriate scans and intervals for chemotherapy or radiotherapy doses. It doesn't just have to be about surgery, but it can all be done manually as well. As I said, we've got a charity involved, so Prostate Cancer UK, and we've basically got a group of about 20 men from different races, so Black, Chinese, Indian, to really help us design this tool to make sure it's fit for purpose for all men, not just a certain group. And we've had to go through a lot of ethical and legal problems as well regarding the whether patients feel it's acceptable for a computer to decide their care. So there's a lot of ethical considerations regarding this as well, which is why at no point in this study is a software going to be deciding without a human or a doctor supervising it. It's recommendations, but the decision still lies with the clinical team. And then we'll analyze this at a report this time next year on the success or failure of this project. The plan is, if it does work, they would like to roll this across the whole of the United Kingdom in 2024. So we think that this view will be more, this is what we see in the future. The same team sitting in a room or virtually to have our Deontics AI software helping with the decision making and of the cancer patients to facilitate our best practice for us. But we think what else is possible in the future. It's all about thinking ahead, maybe 10 to 20 years. And this is my kind of take on how things could go in the future, where you have patients coming in for imaging together with AI software.
Sorry, sir, we can't hear you.
Oh, you couldn't hear the video.
Oh no.
Okay, apologies. Yeah, there was some sound. Okay, could you hear the sound? Okay, not to worry. But basically, I'll describe it. It was just my vision for the future, where we have deep artificial intelligence system, and we're probably about 10 years away with deep learning, where the machine actually uses your own genetic data with the latest evidence and guideline to give patient-specific outcomes for you as an individual. So make it even more specific to the patient. And this is coming, basically. This is where the future is. And I do believe that Africa and Nigeria, we are benefit as well. It's not just something that's available in the West, but for use in Africa as well. And I'm very passionate about that. And I suppose the next question I had is, look, is Africa ready for artificial intelligence? I've heard people say, look, we haven't even got power. We haven't even got this. How can you even be talking about this AI business for us here? But I think that with some of the more basic systems, it can help bridge that brain drain. So as I said, at the moment, I dial into the Lagos Teaching Hospital on a monthly basis to help with that. And we can, and sometimes with the AI, with the latest of the AI solutions, we can actually put cases through And the AI, the artificial intelligence can help, especially in our local population, decide who gets radiotherapy, who are the more suitable surgical candidates, and helps with that. Also with more advanced scanning, such as PSMA PET and MRI scan, we can help tailor resources so we know who is getting, who can be sent for the right scan to avoid overuse. There is the implication on teaching and training, apologies for spelling mistake there, because if you have artificial intelligence systems doing all the work, what happens to you guys, the medical students and the junior doctors, in terms of learning how we conduct ourselves and make clinical decisions? But then best practice, you know, I'm coming from UK. Is it arrogance for me to say, I think I know best and our practice is the best? So what standards can we use? And I said, with the AI, it's trainable, so you can use local guidance and local standards, which are customizable for your own practice. It doesn't have to be an American or UK-based system. Yes, there's a cost implication for this technology, but the work we're doing is really trying to bring the cost down so it can be used in low and low resource settings as well. And we know in Nigeria, telecommunications has really boomed in the last 10 years with good communication and infrastructure. So we think that this technology can be embedded. It doesn't have to be embedded in very high tech. It can be used in low tech settings as well. But then obviously you have an issue with power as well. And I said, we've talked about communications, but I do think that working with partners in Africa and Nigeria, I do think this software is available. You guys have we have a bigger population in Nigeria compared to the United Kingdom. And we just want to try and level the playing field so everyone has access to a doctor or artificial intelligence systems to help with their management. Ultimately, we still have to do the work and see the patients and treat them, but this can really help bridge that gap. So thank you very much for listening for that part of the project talk. The second part I just want to talk about is this, basically. So in King's College Hospital, we've partnered with AfriBank, and we've $100 million just been committed to have the first African Medical Center of Excellence, and Nigeria has been designed as has been allocated the first country to have this. So this is an artist's impression of the building, which is a 500-bed cancer and hematology hospital in Abuja, which is partnering with King's College Hospital. The plan is for this, so the ground is already being committed by the federal government, but for this, there is no involvement. There is no government involvement. This is all private money, and funding from the AfriBank and technical expertise from King's College Hospital. So this is not a situation we're going to drop another white elephant into Nigeria, where it's a building that's just used for the ministers and their family, but this is really going to be utilized for Nigerians and West Africans to have the first-class cancer care. We plan to incorporate artificial intelligence, robotics, and have it at low cost. So the plan is, this is not for profit. So it'll be more wealthier people that can pay will then subsidize the treatment and care for those that aren't able to. So this is not just another, because for me to be involved, I didn't want to be involved in something that is just for rich people in Nigeria to access. This is really going to be for access for all Nigerians, basically. And we're really going to leverage the use of technology. So we've started, the process already started now. The money is already being committed, and it's going to incorporate the best of the UK care. So we have clinical expertise and protocols, very strong governance and admin, we're going to incorporate junior doctor training. So the plan is to have doctors that are employed from medical school, from Nigeria, to be able to come and do clinical rotations at King's College Hospital for training. And then those doctors will then go back with guaranteed jobs to work in the facility. And this is really going to foster research, training, and try and prevent that brain drain, because every month we get hundreds of doctors that come from Lagos, from Nigeria and parts of Lagos and other parts of Nigeria to work in the United Kingdom. But if we feel that if we build a world-class facility and have world-class doctors, there's a better opportunity for people to stay if they know that they're going to be paid appropriately and have access to the best quality care. So this is what's happening in the horizon, guys. This is real, it's happening, and it's really exciting to be part of. And we hope that as many of you guys will engage with us, and you'll be the workforce of the future. Thank you very much for listening to my talk. Any questions?
Thank you very much, sir, for that insightful and great talk. Yes, we have some questions, but guys, if you have questions, if you're not shy, by all means, please raise your hand, and then mute your mic once.
And I know, yeah, and I know there's a lot of students there, so please feel to ask me about anything, basically. I'm happy to talk about any aspect of things, either from the AI side or just kind of other things as well.
All right, thank you very much, sir. And if you're shy, you can simply send a message to the chat box and I can read it out for you. There are already some questions people have already started sending in. So one question says, why did you go back to get a computer science degree? I think that was from it just dropped his email.
Yes, so yeah, I've got my email address if there's any specific questions. But yeah, no, really good question. So my background is in computer science. So before medical school, I was a software developer, and I've always been interested in IT and how IT systems could work. I then kind of did a complete career change and flipped into medicine, and then got through into my surgical training to become a surgical consultant. But I was always passionate about the use of technology, and I think technology can help bridge that divide and gap, especially in lower to middle income countries. So that's one of my passions. That's why I was able to really push with this project. And I think systems like this can really help make a difference to Africans across the continent. And I think we have to be at the forefront of this. And it's not something that's just for the West to be using. So yeah, so that was my passion, and it was just something I was really interested in, had the skill set to try and do. And I think going forward, medical students won't just be a decision about, do I go, what kind of special doctor do I want to be, but do I want to get involved in health technology? Because I think it's going to be the key to really bridge the divide.
All right, thank you very much. Another question says, do we need a bachelor's in computer science? Do we need a bachelor's in computer science to combine tech with surgery? Like,
absolutely not, no. There's a lot of, so if you go to your university, there's a lot of fantastic work that's happening, but the problem is it's all done in silos. So the guys in the university will be doing their work, and the doctors doing their own thing. So having combined units, so at King's College Hospital, we have our computer science and engineering department integrated within the hospital. So then we can really foster better working and better permeation of ideas, basically. So you don't have to go and get a computer science degree. Just being interested and having passion and linking up the right team is what is needed, basically, to get involved.
All right, Felicia is raising up his hand. Felicia Akinwande, you have the floor. Please ask your question.
Okay. Good evening, everyone. Am I very audible?
Yes, you are.
Yes.
All right. Good evening, sir. Thank you very much, Dr. Makanjuola. That was a very, very insightful talk and presentation. So I have just two questions. So I personally have been very interested in artificial intelligence and machine learning as related to surgery for a very long time. I spoke to, I don't know if you know ICAD in France, Institute for Research. Yeah. So basically the question I'm asking is this: is it better to, if you want to in the end go into artificial intelligence in surgery, is it better to get a foundation in artificial intelligence before you go on to residency in surgery? I don't know if you get what I'm saying, because I spoke to one Professor Andrew Gomes. I don't know if you're familiar with the name. He's very big on artificial intelligence and surgery, and he advised that it could be good to do maybe a master's in artificial intelligence first, have strong base in artificial intelligence, then do residency in surgery. So that's my first question. My second question is, how do you, so minimally invasive surgeries, laparoscopic surgeries, and robotic surgery, how exactly, because most of what you spoke about from my understanding was just about like how artificial intelligence and deep learning can help patients, treatment, and all of that. But the surgery itself, procedures themselves, robotic surgery, how does that come in? I don't know if my question is very clear.
Yeah, that's clear. Thank you very much for your question. So in answer to your first question, it really depends. So I had a strong basis in computer science because of my initial degree, and that helped me when I went through my residency. It helped me to kind of frame my thinking and project and research. So yes, having that strong base is helpful, because as you go through your residency, your eyes are more open. You have an understanding of the technology, and there's a lot of gaps and deficiencies in medicine and surgery. We're still doing things we did hundreds of, that are tens of really, really old practices. So with your eyes that are open, with the background you have, it means you're in a better opportunity to exploit it. Number one. Number two, you have strong links from the master's or degree you have. So then you can then bring people into what you're doing. So yes, but then on the flip side, I know people that have finished their residency, really interested in tech, and actually got the right partners involved. So there's no right or wrong answer. Everyone's very different, and I've seen it work from both angles. In answer to your second question, so we do have robotic systems here in the United Kingdom. In the hospital, the trust I work with, we have access to 5 robotic systems. Look, I think we're years away from a robot doing a human operation. You guys are not going to be out of jobs if you want to be surgeons. We're still going to have to cut and diagnose and treat. But there are kind of plans afoot where robotics can help with art in terms of treatment planning for surgeries, also in artificial intelligence in imaging as well. So image guided surgery is coming as well. So, but I think we're years away from that kind of Hollywood. But the work we're doing is kind of laying the foundation for that. You need to have good systems in place, and then you can scale up to apply that to machines.
Yes, very much.
Does that answer your
Thank you
question?
very much.
Any other questions? And I've also left my email address at the bottom in the chat. So if you wanna send me the emails or anything, I'm happy to get those. Anything else, guys?
Yes, sir.
I'll put a question to you guys. Yeah. Go ahead.
I'm sorry. So one says, for students or recent medical graduates interested in working in the African Medical Center for Excellence, how do they and when do they apply? Then another says that apart from,
so that's a really
sorry, I just want to read them all. Another says, apart from artificial intelligence working in surgery, what other aspects of technology can we dive into if we're interested in technology or tech in surgery? Then the last one says, do you need to know how to code to be able to contribute or be a part of AI in surgery?
Okay, so in answer to your first question, if you guys send me an email, I will put you in touch. At the moment, we're still at they're just hiring the executive, so the CEO, the chief medical officer, the chief nursing officer. So the main executive just being hired now. So we're probably about 12 months away from looking at clinical staff. But if you send me an email, I can put you in touch with the team to keep you guys updated. Because for me, the success of this project is not about these doctors or you boy guys coming from London or UK to come and set up hospital and then go back to England. It's going to be you guys that are going to be running this, and the surgeons and the doctors of the future that will be the success of this project. And I'm really passionate about that. So it has to be local engagement, especially with medical students that are going to be the doctors going forward. Because look, if we don't sort you guys in Nigeria, many of you will leave and come to Europe or come to America. So we have to make it attractive financially and good and training wise to encourage you guys to stay. And I think with the project we're doing at King's and other projects coming, I think we can hopefully try and achieve that. In answer to your second question, which was about, apart from AI, any other software systems? Yeah, absolutely. The humble mobile phone, there's fantastic work being done in terms of data capture and surgical planning with the mobile phone. And again, it's very low risk technologies in diagnostics. So with COVID, we've seen a lot of upsurge in remote diagnostics, especially in resource poor areas. So the use of a mobile phone for diagnosis is one. And also in terms of education and teaching as well, the use of very simple tablets and mobile phones to help with training as well. So there are other non-technical things that can be done. And AI, it's not just about the sexy AI, but there are more basic things that are going through as well. And then your final question, do you need coding? Absolutely not. I've not coded now for about 5 years, but I work with a fantastic team of computer scientists and coders who do, and we leverage our skill set off each other basically. So no, you do not have to be a coder to be involved in AI or meditech. Does that answer the question?
It does. Thank you. Sorry, another question. So it says, so that means that students can also do their electives in the hospital. That is, students from Nigeria can do their electives in the hospital.
Yeah, absolutely. But I'll spin on its head. You don't always have to do clinical electives. Why not do an elective with Google or do an elective with an AI health tech company to broaden your mindset? The days of just going to a hospital, contacting them, standing, watching surgery for 2 hours and watching clinics. Yes, it's good, but it's not appropriate for everyone. And sometimes you have to think laterally. And there are offering, especially for African students now, to go to California and San Diego and do internships in health tech companies as well. So you have to really think quite laterally and don't just think about the traditional way of doing things. Although they're appropriate, there are still other ways of engaging with health tech, or splitting it so you do some part in hospital, but you do some of your time working with a tech company as well. And there's some really cool local tech companies in Lagos that are trying to do some really good things as well, that we've been engaging with. So it's happening locally and internationally as well.
All right, thank you very much, sir. There was something you wanted to share with us before I cut you off, sorry.
Sure, go ahead.
No, I said there was something you wanted to tell us when the questions were coming in.
Yes, no, I was just saying that you guys are for the medical students, you're really at a cusp of some fantastic innovation now, basically. There's a lot going on in the space. And because you're in Nigeria or Lagos, Africa, it doesn't mean you're excluded. There's some really, really good local things that are happening right now. And if it's about networks and getting yourself connected to these networks so you can exploit it. Even as medical students, you still have knowledge, and it's still valuable for technology companies, the medical knowledge you have. So don't think that because you're a junior medical student, you can't be involved in this. And actually, we have a master's program. We take about 50 students a year, and some of the best ideas have come from our students actually. And one or two have gone on to become spin-out companies and done really good things. So don't let your kind of junior status limit you in terms of what you can do. You may be the next African Bill Gates sitting amongst us here.
Okay. All right. Thank you very much, sir. Please, if you have any questions, you can just send them to the chat box. If you are really, really shy, then you can just DM me. That is, send it privately to me in the chat box. And if you're bold, by all means, please raise up your hand so that we can let you speak.
And please feel free to ask me anything. I'm pretty open. I can talk about money and finances if you want. In terms of the we've raised 1.2 million pounds. Most of the money has actually gone to the technology company. As you can imagine, the creation of the software and the developers, most of the money goes to that. I've decided not to take a salary from the project because I really kind of passionate about it. So I've not taken a salary, but there's still opportunity from the research we've done to create a spin-out company, and that's what we're planning to do, to commercialize this and sell this across the NHS. So yeah, so it can be lucrative for you as well if you kind of have that business mindset as well. Are there any other questions?
There is another question. Sorry, I'm just trying to read it. All right. So it says, thank you so much for the talk. My question isn't related to tech. From the talk, I learned, sorry, I think whoever sent it, please, can you resend it again? It seems like it got cut. I can't see the full question. Or you can just send me a DM.
And actually, there probably is one thing I can share. My group, so we set up a company basically looking at telehealth in Africa, in Nigeria, and it was called Medics to You. And we're about to start doing video consultations and offering services to, as a urologist, I do men's health clinic, but COVID kind of came and it kind of slowed things down. But we've just been awarded a contract to develop a day surgery unit in Lagos, in Lekki. So again, with the use of that building, we're planning to kind of be very technology focused with it. We think that there's a big market in Nigeria. There's potential and scope with local partners and local tech companies to help really build something that's Nigerian centric. I think in the past, things have been bought from United Kingdom or US and dropped into Nigeria and expected to work. And no one's built anything from the ground up, or very few things. So we're hoping with the projects we're working on in Lagos, we can try and fulfill that and just show that it can be done.
Thank you very much, sir. So the question, I can read the question out now. So the person asks that from the conversation, I learned you studied in the United Kingdom. What's the fate of a non-UK graduate who wants to become a surgical consultant in the UK?
That's a really good question. So you have to do your PLAB exams, which is your kind of the UK licensing exams. So that's one step. But the really important step is actually being able to do some internships in the UK. So they like for you to have spent at least 2 to 3 months shadowing doctors, being in the NHS system. And obviously that's a great cost to yourself because you're not getting paid for that. And in that time living in the UK, you got to pay your accommodation and provision. So it's not cheap. Once you've done the PLAB exam and you've managed to get your GMC number, then you have to apply for resident programs. Initially, they're standalone and they're called service jobs. So you do 1 year as a house officer, 1 year as an SHO. And then what you want to do is then get into the system and get that training number. So it's very competitive in surgery, for example. So, but there are less competitive areas such as GP or psychiatry, which has always been historically been that. But I've got a colleague who came from Pakistan, didn't speak much English. He basically came in and worked hard. Under our guidance, he managed to stay with us for 3 years and managed to get a training number. And now he's into the UK system. So once you get your training number and you're in the system, within 5 years, you're trained to become a consultant. So, but the bottleneck is initially doing a PLAB exam to get in. Finding a job, your first NHS job, can be quite difficult. Sometimes you have to go to places in the UK that the UK people don't want to go. So you may be sent to Northern Ireland or Scotland where it's very cold. But you do your year. But the key thing is getting into the system as quickly as possible and getting your training number. And it's not impossible if you have the right team and mentor with you, that can be done. But it is a lot. There's a lot of sacrifices you have to make. At the moment, we've got we just employed a doctor from Lagos. Her name's Ijoma. She's really keen to kind of become a urologist. So we've kind of supporting her through that, and hopefully we'll support her through the application for her training number in the United Kingdom. But it's not very easy, but with the right support, it's possible. Does that answer your question?
Yes, thank you very much. So another question is, you are an urologist rather. So the question is there a specialty basically just for technology? Like if you just want to do medical technology, that you can do a residency in it, or you need to specialize in something else, then go into technology alongside it?
Yeah, to be honest, there is no specific specialty. Any specialty has technology embedded in it. So urology, we were the first to introduce robotics into clinical practice. So urologists naturally tend to be more techie. But I've got colleagues who are gastroenterologists, rheumatologists. Health tech is in all aspects. Wherever there's a health need and there's a population need, technology, there are solutions that can help fill that gap. In the UK now, there are a lot of more technology fellowships. So my institution, in the summer, we're starting the first technology fellow. So we take technology, AI and technology division and engineers to really exploit the use of health technology. So you take a year out of your training to do this, and then after a year, you go back into training. So these fellowships are now becoming more and more common as doctors go through their training. But there's nothing specific as a health tech residency, no.
All right, thank you very much. And then the last question will be entertaining for today. Oh, okay, another question just entered. Okay, so okay. What would you advise a medical student or a resident or a recent medical graduate who is interested in technology or is interested in AI, to be precise, to do to make them more competitive, especially if they are not necessarily coming to the UK, if they want to go to the US or elsewhere, to make them more competitive?
I think the key thing is networks. You have to have a network. You have to have done your internships. You're going to have to work for free. So, engage with the local tech companies, add value to them, help with development of their decks, which is their development project posters, get involved in projects, try and add value to these companies. So then it helps boost your CV and you understand the way the development process works. So then, so there may be opportunity to stay on them as a chief medical officer for them if there's an opportunity, or you can use that to leverage working abroad as such like. So really, for the medical students and junior residents, internships and just getting involved and adding value to the companies is really, really important, basically. And it helps grow your network and then find opportunities you can then leverage and move on to, basically. I think that's critical.
All right, thank you very much, sir. So the last question. Good evening. Thanks for the beautiful talk on AI, on how AI is moving trends, obviously. So the future is really data-driven and automated. And this AI interface is a beautiful innovation with your passion in tech and automated system. How does clinical practice tie in with your passion with technology? And if you had to choose one of the two, I mean clinical practice or tech, which would you choose? I think that's it. Yeah.
So I've been a consultant now for 5 years, and you realize it kind of gets very repetitive. You see the same patients, and obviously I'm passionate about patient care, but as a surgeon, I can only impact on one patient at a time. With AI, I can impact on thousands or millions of patients, basically. So as I get more senior, I do probably will phase further away from clinical practice and the kind of the daily grind of being in a theater and seeing patients and doing ward rounds, and move more towards health tech, where I can impact more on a population level. So for me personally, I think I will phase slowly away from that into more tech, more full-time as I get more senior.
All right, so the question about if you had to choose between clinical practice and tech.
If I had to choose, I'd say I'd have both. If you forced me, I'd probably say tech, because I think I can make more of an impact with the tech than the impact I make doing one operation on one individual, basically. So yeah, technology wins for me.
Okay. So thank you very much, sir, for this wonderful talk. I'm sure everybody is just trying to take it in like, oh my, this has been really nice. So thank you so much for sharing from your wealth of experience. We really appreciate it. And for those of us new here, those who haven't, who do not have any experience with surgery. So as I said earlier at the beginning, we are the Surgical Interest Group Lagos, and we are an organization that consists of both recent medical graduates and medical students interested in pursuing a career in surgery. And we provide research collaborations, mentorship programs with surgeons, surgical skills training. Our next surgical skill training is going to be in March, or our first one is going to be in March, and webinars, insightful webinars such as this, to equip our members with sufficient knowledge, inspiration, and skill to help them in their future careers. So thank you all for attending. Please, if you're not following us on social media, check in the chat box. We are on Instagram, we're on Twitter, we're on LinkedIn, and we have a YouTube channel. For your friends who missed this webinar, they can go to our YouTube channel and watch it. So thank you very much, sir. Once again, we really appreciate it. And he has also dropped his email in the chat box. So do check in the chat box if you have questions, and maybe they're a bit personal but related to technology, and you really would like to ask him directly, by all means, do so. Thank you everyone for attending. It's 1 minute to 9. And we'd like to call it a day. Sir, do you have any closing statements for us?
No, I just hope I can kind of inspire you guys to get involved. Don't be limited by your location or circumstance, because, you know, from anywhere, anything is possible, basically. And I do think going in the next 5 years, Nigeria, especially as Nigerians are very resourceful, and I think the future of technology in Africa will start from Nigeria, actually. So yeah. All right, thank you. And I hope to collaborate with some of you soon. Take care.
Thank you. Talking about collaborations, we also run a mentorship program, and we would like to ask if you will be open to, you know, members having been a part of the mentorship program, sir.
Sure, absolutely. And actually, I'm part of the British Nigerian Doctors Association in the UK. So you know, I'm happy to connect. I can be a conduit to connect some of you guys with our colleagues here. So these are Nigerians who are based in the UK. To help as well. So yeah, I'm happy to do that.
All right.
I'm just going to put my email address in the chat again if you want to contact me.
All right, thank you very much, sir. So I think that should answer a question about the details being resent. Yeah. So his email is in the chat box. Thank you, Chukwebuka, for sending it. It's in the chat box. And everybody is saying a huge thank you, sir, for taking time to come and speak to us. We really appreciate it.
Thank you. Anytime. And if you need more speakers on different topics, just let me know, and I'm sure I can find a friend who is an expert on that area to come and give you a talk to you guys.
All right.
I think it's really important as Nigerians in the UK and America to really engage with you guys, because we can't just be sitting in England saying we're fine. We're not going to, we have to give back and help and make sure we bring everyone up as well. So I'm very passionate about it.
All right, then. Thank you very much, sir. So once again, follow us on social media, and by all means, do have yourselves a great weekend. We'll be ending the seminar now. Thank you all for coming to the meeting.
Bye. Good night. Bye.
Good night.